Wonderful.
Welcome, everyone. Today we have a very special speaker, and that speaker who was going to speak to us in the middle of the snowstorm last winter. But the weather is nice today, so she's here with us and rescheduled today. It's Dr. Pamela Mitchell. And our chair, Dr. Veith, is going to be introducing Dr. Mitchell.
Thank you, Sharon. Sharon thought since we're having a dean, perhaps the chair should introduce her. So I'm happy to do so for a lot of reasons, not the least of which we've worked together on this and other projects for 15
long time.
Long time. So let me tell you a little bit about her details. It's a pleasure. I'm also delighted to have someone who's been at the university longer than I have been. She started here in 1969 and as an acting assistant professor. She got her PhD here in 1991 and has kind of matriculated her way up through the infrastructure of the nursing and health sciences domain for all this time. She began being the dean for research when I first started interacting with her. When was that? Mid-90s? Mm-hmm. I had been working with Marie Cowan before her predecessor. And just to demonstrate that no good deed goes unpunished, she's now the interim dean for the whole School of Nursing. And the Reed Endowed Chair, is it? Deanship in the School of Nursing. A few other very important details. She's a professor in biobehavioral nursing and health systems, has an adjunct professor appointment in the Department of Health Services in the School of Public Health and Community Medicine. She was the founding director of the Center for Health Sciences Interprofessional Education, co-director of the Research Education Core in the Institute for Translational Sciences. Her research over the years has focused on very interesting areas of the fundamental physiological factors influencing responses to critically ill patients in the neurological cardiovascular domains principally. She's done a lot of both development of treatments and dissemination and trials of translational research efforts to improve quality of care in those sorts of populations and looking at the effectiveness of care. As you might expect, given her talents and her long-standing research and educational efforts, she's published more than 200 articles, books, and chapters and things. She's, of course, recognized beyond our local home territory, where we value her tremendously. She's been the past president of the American Academy of Nursing, a member of the initial review group of the National Institute for Nursing Research. And as those of you who may not know, our School of Nursing has been for many years the #1 research nursing school in the country. So she comes from and contributes as really good stock. She's on the expert panel for quality health care for the American Academy of Nursing. Has been on the editorial board of journals in the areas of biological research and nursing for some time. Of course, she's acquired a number of awards and accomplishments. I'll highlight two of them. One is the 2011 Ada Sue Hinshaw Award by the Friends of the National Institute for Nursing Research, which is presented to nurse scientists who make a major contribution to improving health care through research. And in 2010, was selected by the Sigma Theta Tau International as an inaugural member of the Nurse Research Hall of Fame. She's also on my dream team and my Hall of Fame, which is not quite so consequential, but means a lot to me. So it's been a real pleasure to work with her and her team. She embodies what I think our institution really values, is someone who can work across disciplines and across departments and really enhance all of our work. And it's a pleasure to have her here talking about one of our research areas. So please help me in welcoming Dr. Mitchell, who's going to talk about stroke and depression.
Thank you, Richard. People need to sort of get coordinated on heights in this. There. Can you hear me? Actually, that probably is recording rather than you hearing me. So, well, it's really my pleasure to be here. Harborview is one of my homes, and this research study has been just terribly important in my professional life and with many colleagues that that I've been working with in the course of this. I think Richard really hit the passion of my work in both clinical and research work, which is interprofessional, interdisciplinary, across the disciplines, because the problems that all of us study aren't things that are easily addressed by any one individual, and it truly takes a team. So I'm proud to be part of this team. What I will do, being someone who gets CE for events, I put my objectives here so that if you're getting CE, you know where I'm going. So I'm going to talk very briefly about the scope of the problem of depression and stroke. I'm going to talk very briefly about the evidence base for both pharmacologic and non-pharmacologic treatment in post-stroke depression, and then talk to you about our Living Well with Stroke trials that incorporate a brief psychosocial intervention that's adjunctive to pharmacotherapy. I don't think this is a group that I need to tell how big a burden, health burden, depression is. It's the leading cause globally of years of life lived with disability, and the fourth leading cause of reduced disability-adjusted life years, both in an individual's productive life and taking into account premature mortality. That's depression in general. And depression related to stroke is an equally big problem. The numbers change depending on what year you look at Heart and Stroke Association statistics, but there are roughly 750 to 800,000 new or recurrent strokes at both ischemic and hemorrhagic every year. It has moved now, stroke has moved to the fourth leading cause of death in the U.S., but it's still third worldwide, and it is the leading cause of long-term serious disability in blacks more than whites, in American Indians more than Caucasians, and in women more than men. So having depression on top of having had a stroke then becomes a doubly disabling problem. There have been a number of meta-analyses, not so many recently, but in the past, looking at the frequency of depression after stroke. And when I say post-stroke depression, what we're realizing now is it isn't necessarily that it just started after after stroke, but is often present before. So most of the early studies only measured people's depression after they had had a stroke. So it's about 35%. In people who are older than 65 years, taken from the Framingham study. The synthetic reviews of numerous epidemiologic studies also pool the estimate of the prevalence of depression following stroke at about 33%. The range can be anywhere from 10 to 55%, depending on who you sample and whether they're out in the community, whether they're in different kinds of hospitals. But I think the 33% is probably pretty accurate. That reflects both the incidence and prevalence, and as I'll come back to later, it's a misnomer to call it post-stroke depression, at least in our studies. Two-thirds of the people who had depression that was identifiable after a stroke had had one or more episodes in their lifetime before, or relatives with it. So what happens when you're depressed after stroke? Same thing that happens when you're depressed in any time of life, that there is a reduced quality of life. In terms of stroke rehabilitation, there are poor rehabilitation outcomes that really are not related to the severity of stroke, but to the severity of the depression. And actually, this slide could be updated. There is an increased risk of subsequent stroke, other cardiovascular disease, and death. At the time we got this study started, it was not so clear if it was really an increased risk, but more recent studies, this is from 2011 in the JAMA, and you can see the red circle over the pooled estimate. So there's about a 1.2 increased risk of death in a meta-analysis of deaths following depression preceding stroke, so the incidence of stroke, and of death. There's also an increased risk in the meta-analysis that have been done. So it would be good if we could do something about depression. And that's the big question, is if we treat the depression, then do we change this? And I think the answers aren't all in yet. Many mechanisms are postulated, certainly biological. Does the tissue injury from a stroke damage the neural circuits regulating mood? Are there changes from the stroke damage in serotonin signaling disruption? And perhaps there's a genetic propensity both to that damage or to becoming depressed given the incidence of stroke. There's certainly a number of theories related to inflammation and cytokines. Then, of course, there are the psychological theories, the, quote, reactive depression. Who wouldn't be depressed? You just had a stroke. Well, 67% of people who've had a stroke aren't. So that, there's something perhaps in addition, and I think the best explanations are probably a biopsychosocial combination of some propensity to depression, the injury that has occurred, and some of the biologic markers, as well as one's way of viewing stressors in life. This is a slide to kind of look at the, I guess I can, oops. That didn't work. Okay, try this again. What I'm trying to do is get the, no, I can't get the marker. So this is a slide that's taken from PET scanning about the areas of the brain that are active in response to psychosocial treatments, in response to antidepressants. And the thing that I want you to take from this is that this was done in relation to whether cognitive behavioral therapy is better than antidepressants, is it better in combination? And this slide suggests why the findings that it is better in combination of talking therapy and antidepressants might occur. So up in the red is, this is really upside down. I think I'd look at it totally differently. But so these are changes in the hippocampus, which are not very responsive to talking therapy. But the green, the mood state and the self-reference components of the brain were more responsive to psychotherapy, and the hippocampus, some of the more vegetative components of the brain are more responsive to the drugs. And so, if indeed the drugs help us with our mood, but there's also a component of how we view life, might explain why the two together work better than either one alone. And that certainly appears to be the experience in our study. Another question to ask, is because stroke has had some brain damage and brain structures are involved in mood as well as in motor function, is there more depression after stroke than in other chronic illnesses? And the answer really is no. This particular slide is relatively old, but shows particularly over on your right, diabetes, stroke, chronic lung disease, all chronic illnesses, all have an increased prevalence of depression than do people of a similar age. If you can read the numbers, pay no attention to them whatsoever, because they're not in the same values that I was showing you earlier, but simply showing that for many of these chronic conditions and also with cancer, that the incidence prevalence of depression is higher. And I don't think it's because of brain damage specifically. I think it's something to do then with the chronic illness. This one is, I actually did this recently for the neurology residents, and so this is in there for everybody who's a practitioner, how you might briefly identify whether somebody is depressed following a stroke, and it's pretty simple. You ask them, do you often feel sad or depressed? Many of you may recognize this as part of the patient health questionnaire, the PHQ-9 or 2. So you can expand it a little bit over the last 2 weeks. Have you been bothered by having little interest or pleasure in doing things, feeling down, depressed, or hopeless? And how often was that? Not at all, up to nearly every day. We've certainly found with the folks in the stroke population that asking them, are you feeling sad or blue, is often a very good way to do it. A lot of folks don't necessarily want to endorse the term depressed, but when you do a further screening, they indeed have all the signs of it. But sad or blue is something they're willing to talk about. So it's very simple to ask that. You can also, of course, do more extensive screening. We use the geriatric depression scale, which has either 30 items or 17, depending on what you're doing. It isn't just for old folks. We've had some grant reviews that suggested that this was totally inappropriate to use the geriatric depression screen on people who aren't geriatric. Wrong. It is a really good screen. The reason it was developed for the geriatric population was because it doesn't weigh so heavily on some of the motor functions that can slow down simply because you're older, or also with a stroke. So it's a good tool. The patient health questionnaire, the PHQ-9, is quite good as well. Beck Depression Inventory is used by some people, but it's longer, and it's actually not as sensitive, I think, to the depression following chronic illness. All of these will pick up depression, depressive symptoms that are consistent with the DSM-4 criteria. And I'm probably behind the game now because the later ones have come out, but nonetheless, not quite out, but nonetheless, I think it works pretty well in terms of major depressive disorder. And then this is just a slide that has the PHQ-9, and of course you can't read that. So it's quick. It can be used clinically very, very well. In fact, a number of clinics and agencies are using it as a routine part of screening for people in outpatient clinics. So how is it treated? Certainly antidepressants are a mainstay. Tricyclics haven't been used as much in stroke patients because of their cardiovascular effects, but certainly the SSRIs in the newer generation work reasonably well in some of the people. They don't work in everybody. And non-pharmacologically, there's a growing use of talking therapy, is essentially. Cognitive behavioral therapy has been used, classic cognitive behavioral therapy, brief psychodynamic problem solving. What we're using is a combination of problem solving therapy and pleasant events, helping people reframe how the world is interacting with them. And I'll talk more about that in a bit. There were relatively few studies of the psychosocial or non-pharmacologic up until this last decade. And the ones that were done, in fact, the ones that were reviewed in 2005 were kind of terrible studies, as a matter of fact. And so it wasn't very conclusive, but we based ours on some really much better studies in people with dementia. So I think I've already talked about in the non-pharmacologic. There are several newer studies, including ours, that combine some kind of psychosocial intervention with pharmacotherapy. Our group, the group from, I've suddenly forgotten where they are, Indianapolis, with care management, which is a much more clustered care with post-stroke depression and antibiotics that are tailored with a nurse practitioner guide, and then motivational interviewing early after stroke. There's also a preventive study that was done at Ohio State with using either antidepressants or a combination of CBT and antidepressants in everybody who had had a stroke, trying to prevent depression. And it appears that that was very effective. But again, the combination was more effective than individually. And you really have to have a whole lot of people if you're going to do a prevention trial, because if the incidence is only about a third, then you've got to have a whole lot more people to know that it was less than that. We have been, over the last, when did we start this? 1996? Something like that. Over the last, how many ever years that is, I'm sorry, I haven't had lunch and I can't do the arithmetic. We have had a number of papers from the first stage of our study, the Living Well with Stroke trial, which combines the psychosocial behavioral intervention and antidepressants, and then also looking at the association of serotonin transporter polymorphisms with both with the incidence of post-stroke depression in these folks and their response to therapy. And I'll talk a little bit more about that as I go on. And those all involve many people well known to you in this room. So let me tell you about this study. If you want to interrupt with questions, please feel free to do so, or we can save them to afterward. I know the people who are off-site can only get their questions in afterward. So this study has been financed by the National Institute of Health, National Institute of Nursing Research now for, we are in our 8th year, going into our 9th. And the basic finding is in the title, that this brief psychosocial behavioral intervention in combination with antidepressant reduces post-stroke depression significantly more than usual care. So our trial design was to take everybody that we could find who had had an ischemic stroke. And we started out, the first study was only people with ischemic stroke. We started out with Harborview and UWMC, expanded a bit to the VA, and then finally to Northwest. A lot of people have strokes in this area, but a lot of people are hard to get into this whole screening process and get into the study. So we followed about 1,000 people in these 3 hospitals right after they'd had a stroke. Of those 1,000, there were about 300 who agreed to be screened. And at that time, we were asking people who had already been identified as being somewhat sad. So that's, about a third. Of those who were eligible that had screening GDS high enough to have significant depressive symptoms, 148 were eligible, and we randomized 101 out of that. So that is that's the nature of post-stroke depression trials. There's a lot of legwork to get people into the trial. We then randomized people with a computerized algorithm that takes into account the severity of their stroke, their age, and the severity of their depression, so that we could balance that across the groups. And then we had 48 who had the psychosocial intervention, the talking therapy plus antidepressant, and 53 with antidepressant alone, which was the usual care. That was the intent, is that they all had antidepressants. About 70% of people actually did. But so they were randomized either the control or the active, and then we followed them immediately after the therapy period, which was 9 weeks, again at a year, and again at 2 years. That's the longest follow-up that I'm aware of, even today, in these studies. And we were able, we didn't have that many people. We kept most everybody at 1 year. The reason we had only in the 30s at 2 years is because we ran out of money, not because people had died or otherwise. So we were able to keep people really through the 2 years, including in the control group. So everybody got written materials about stroke and depression from the American Heart Association, which are kind of okay. It was recommended that everybody receive an SSRI from their own provider, and Dr. Veith and I wrote letters to their providers that they were in the study, and kind of recommended what we thought would be good. They might follow it, they might not, but most people were prescribed an antidepressant. And then everybody kept a medication log for the first 8 weeks, which enabled us to keep in touch with them, which also gave people in the control group something to do, and we were able to look at compliance with the prescribed medications, and then did the follow-up using the Hamilton Depression Rating Scale, the Stroke Impact Scale, which is a very nice scale of people's perceived function and perceived recovery from stroke. If they had a partner or caregiver who wanted to be part of the intervention with them, then that person did some ratings about caregiver burden, and then we did a Barthel Index on the patients, not the caregivers, at these follow-up times with respect to motor function. So what this protocol is about, this was based on work that Linda Terry, who I think is also familiar to many of you, had pioneered with people with Alzheimer's disease who were living in the community and who were depressed. There were a couple of important things she showed in those studies. Number one, you can measure depression in people with Alzheimer's. And then they developed this treatment, which is known as the Seattle Protocols, in which for the people with dementia, they and their caregiver were a pair for this. And so it teaches people that the behaviors that are part of depression are things that have to do with interactions with the environment. The expression of your mood is a behavior, and there are things that can be modified in response to that. So what folks do is have a whole series of meetings with the therapist in which they talk about, they first start out looking at what things are pleasant events, what has been pleasant in the past, what is still pleasant. So it really starts out not from solving the problem of feeling low and blue, but what still makes you feel good. And for some people, there wasn't a lot. But the goal then is to increase those numbers of pleasant events over time, and also increase the physical activity and moving around to improve the mood. We didn't talk about depression until the very middle of this whole thing. And then people are taught some behavioral strategies to reduce or prevent their behavioral responses or the mood disturbances. And these are individualized to the problems the person is perceiving. Then there's also, it wraps up with some generalization. So first week is just an introduction to what behavior therapy is about, how to identify what your behaviors are, how to identify what came before them, and how to identify what you did about them. And then also identifying pleasant events, and there's a very long protocol checklist. The only thing we did in modifying this for people with stroke was to change the word memory problem to stroke. And that literally, there was nothing else that changed in this Seattle protocol. By week 3, folks are working on scheduling pleasant events and finding ones that they can still do in face of the stroke. Then they begin to identify what things are problems for them, how to break that apart into small, manageable chunks, and then begin to plan to solve the problem. One of the things, it's not just people who've had stroke, but sort of catastrophic thinking is very common, both in depression and in folks with stroke. And so helping people take that everything will fall apart down to something manageable about what can I manage and what will I do next. If they have a partner or caregiver on about week 4, then we talk about strategies they can use both for their own frustrations with the behavior and the problems that the patient is having, and how they can help support their person with a stroke in these positive behaviors. It's week 5, halfway through, we start talking about actually managing the depressive behaviors, using the term depression, and people get into it by then. Week 6 looks like classic cognitive behavior therapy, how to manage negative thoughts, how to change over to what I can do as opposed to what I can't do. Week 7 is talking about generalizing these skills, what you might do in the future, and then week 8 is the review of the skills and the generalization. We had no idea if people could generalize this to all the things that are going to happen to them in the next year or 2 years. So we didn't know if they would maintain the gains that they had, but they did. And that suggests to us that this was something that's generalizable and that they were using. I'm not going to go into detail on the various measures. We can come back to that in questions. In this first group, we were well divided between men and women. I'm sorry, we were not well divided between men and women. There were 60% were men and 40% were women, but they were well divided between intervention and usual care. They were indeed in the somewhat older age group, but notice the spread that we had a number of young people in both groups, and we continue to do so. About a third were married or partnered. They had a moderate level HDRS, 20, 19 and 20, so there was really more a moderate depression, and the not totally mild stroke, but not severe strokes as well, although again it ranged. At the start of the study, people perceived themselves between 40 and 50% back to what they had been before. So that's part of the stroke impact scale. This was, at least in that version, a very successful, on the average, as one always does, a successful intervention. So in the darker purple is the control group. In the lighter purple is the intervention. At entry, they were pretty identical in their depression scale scores. By the 9th week, at the end of therapy time, the intervention group had dropped their score on the average in half, and they maintained that out to 1 year, and actually out to 2 years, although I don't have the 2 years on here. If we look at a score of 9 as one of many remission scores, most of the group in the intervention group were in remission at the end of the treatment time and continued on out to the 2 years. So that was really quite encouraging. This is another way to look at it. When we looked at the percent of participants who were in remission in the intervention group, nearly half were at the end of the intervention time as compared to less than 20% in the control. If you come out to 2 years, it took 2 years before the people in the control group got to the same level that the people in the intervention group did right away. So there's two messages in that. People do get better, even if we're not doing things with them, but it took them a whole lot longer. And the people who did get better rapidly and went into remission in the intervention group maintained that. In fact, we were out to 2/3 of people in the intervention group being in remission by the end of 2 years. So the natural recovery coupled with that appears to be worth exploring some more. This is, again, not one I expect you to read, but the point is, of the people in remission, they all had significantly better scores on the stroke impact scale in terms of their strength, their mobility, their participation in the environment, their communication, their work and recreation, and they perceived themselves as nearly fully recovered at this 9-week time if they were in remission, fully recovered from their stroke, compared to only, again, about half in the other group. So this seemed to be better at getting people in remission, and being in remission then correlated with better quality of life outcomes. But we were very interested in some of the genetic propensity in terms of recovery. So Ruth Cohen, who is one of your colleagues, has been our faithful partner in some of the genetic work. And we were particularly interested in the serotonin transporter gene and in 5-HTT-LPR, the short allele, which has been associated with depression, with a greater incidence of depression in a lot of studies, and has in several stroke studies, including ours, was associated with a higher incidence of depression. The way since everybody in our main study was depressed, what we did was take the people whom we had screened who were not depressed and measure this allele in both. And it was far more present significantly more in the people who were depressed than or not, who had all had strokes at about the same time. We then were quite intrigued with the fact that it appeared that the people who have the one or two short alleles were far more responsive to the psychosocial treatment in combination with antidepressants than people with the other alleles. So the people in blue are these are box plots of the people who were in the intervention group are in blue, those in the control group are in red. And you can see that people who had no short alleles in both the intervention and control had about, on the average, about a 25% reduction in their Hamilton score. That's over here on the left, and the bar is the median response. People who had one S allele were more likely in the intervention group to have on the average, about a 50% reduction in the Hamilton as compared to people in the control group who had none. And people who had two of the S alleles had about 75% on the average reduction in their Hamilton score as compared to the control group had about 25%. Now, the big caveat on this graph is that there are not very many people in that little blue box. So we're proceeding in this next study to try to get a larger sample to see if this still holds true. But given some of the literature about the kind of environmental person interaction of people with the short S alleles, that has nothing to do with stroke, but suggests that in everyday people who aren't depressed, who haven't had any bad kinds of things, people with the short alleles tend to have a more pessimistic view on life. People with the long alleles tend to have a more optimistic view on life. I think our study says, if this holds up, our study says you can change that. So you may be a natural-born Eeyore with the big black cloud, but you can learn to move that cloud away. So that's kind of where we're going in this next study with that. So what we're doing now is we have the second phase of the study. So we've done two things. We're doing a comparative effectiveness study of the benefit of telephone intervention versus in-person for the same thing, and again with usual control. We have a really difficult biostatistician in our group who keeps insisting we have the usual control, which of course makes it harder to get enough people, but appropriately so. So we have three arms now. We have in-person, by telephone, and the control of basically seeing your own provider. We are genotyping everybody that we've screened and who are in the study for the serotonin transporter gene, also brain-derived neurotropic factor, which seems to interact with the serotonin transporter in terms of responsiveness to stress. And then with the influence of Kira Becker, one of the neurologists on our team, excuse me, we have also added measures of fatigue, perceived fatigue, and some very short measures of fatigue and sleep and wake, because of the complete intertwining of fatigue and depression. All the depression scales do ask you about your energy, and it's really hard to disentangle. Is the fatigue because of the depression? Well, the fatigue didn't lift as much as the depression did in our previous study. And people, up to 75% of people following a stroke are very seriously fatigued, even if they're not depressed. So as clinicians, we think these are probably different animals, if you will. So that's what we're trying to do now, is get a better handle on that. And if NIH would give us just a little more supplemental money, we would be able to tease that out just a bit better. What I hope will come from this is, if telephone intervention is as effective as it is in some other areas and is as effective as in person, then this gives us a basis for really taking this into everyday practice, so that when you're discharged, part of your stroke bundle is that you get follow-up telephone calls from the stroke nurses. And that could even be staged first to see if people, if their mood has changed. If it has, this intervention could be delivered over the telephone and could be very cost effective. If it hasn't, then we just follow you up a little bit later and see how things are going. But we're only, we still have 2.5 more years to go on this phase of the study, so the story's still out as to whether or not that's going to work. And I would like to end this up with the village and the teams who have been involved with this, many of whom are here at Harborview, and almost everybody's still with us, even from Team 1. So I would entertain your questions. Yes?
I have a short question and an idea based on the answer. Was there a difference in the severity of any of the elements of depressive symptoms in short versus long allele prior to treatment as a starting point?
Oh, that's a really good question. We haven't looked at it, but we could.
The reason is I would predict it might not be, but that I wonder if short allele makes people more sensitive to psychosocial interventions,
Yeah.
rather than, I mean, the ER idea is another interesting thing too, but that that these folks are more sensitive, and it can play out different ways. It can play out for good or for ill, and so it's not a good or a bad phenotype. It's a sensitive phenotype, and that we might be able to identify who might benefit from psychotherapy.
Right.
With that kind of a quick test that Ruth would make available.
Yes, no, absolutely. Our speculation about Eeyore or not. I'm sorry, I'm supposed to repeat the question because the people out at the U have no idea what you just said. So, so the question is whether before the treatment, the people with the two short alleles had a different sort of constellation of symptomatology, depressive symptomatology, and if not, then was it the short allele that makes them more responsive? Is that what you're saying? Okay.
I wonder if they're more sensitive, their brains are more sensitive to social interactions.
Yeah. Are their brains more sensitive to social interactions? And one possibility is that they view the world more pessimistically. Another is, there could be a whole bunch of that they find the social interactions more stressful, or even the stroke was more stressful. That can well be teased out, I think, with this larger study, because I think there were only 10 or 11 people in that little blue box, so that was small. But we can tease that out better with this larger study. And indeed, that's what our hope is that if, rather than throwing one therapy at everybody, if we could tailor this to people who were likely to get the most benefit. Saliva works really well. That's what we're doing, is just a little saliva test, and doing Ruth could do that. That's what we're hoping to do. Does that answer it? Yeah, good. Yeah.
Yeah, great research, and actually it's remarkably similar to the sort of traumatic injury stuff we're doing, where you have an acute event and then you have this nice gradual recovery curve in many people. But if you add meds and psychotherapy, hey, it gets better quicker, right? We did a study a while back with Gordon Rubenfeld, who used to be here, and it was an ICU study with folks who had been mechanically ventilated for 5 days and had ARDS. And there was a subgroup in that study of folks who didn't have that gradual improvement trajectory. Often they were elderly folks who, say, got a pneumonia, and this was the beginning of the end. There was now a cascade of medical events, and they could see their own mortality on the horizon. And in our sort of collaborative care intervention group, we were trying to get psychotherapy and meds, but those folks were recalcitrant to the intervention. So I'm wondering, it looked like you had a large group of people recruited into your study, but in the more severe strokes, where there wasn't as much sort of optimism about recovery, amongst caregivers and the providers, and may have been like a biological basis for a straighter line. Did those folks respond, or do you think about different interventions, or what's the story with that?
No, it's a really good question. I can't possibly capture it all, but with these trajectories of response, and he was talking also about earlier study with the folks with the severe lung injury, and I think there's about the same incidence of depression there. So, did the people with worse strokes perhaps not respond as well, sort of viewing this as part of the trajectory of the end of life? From a statistical standpoint, I can tell you it didn't matter. We did adjust for the severity of the stroke and actually the initial severity of the depression and all those other factors, and the responsiveness really only came out with the phenotype. The genotype, and so.
But you see, so to me, because what we ended up doing with those folks who were kind of moving towards the end of life, it wasn't like a CBT, hey, we'll activate you.
Right.
Back. This is more like an existential, okay, this event has happened, and there are ways to reframe it, but sort of the theory behind the intervention would change. But it didn't, unless you had an existential piece to this.
Yeah, now I understand. Yeah. So basically, with the folks who were truly at the end of life, what's pleasant for you today probably isn't necessarily the most helpful.
But funeral plans.
Yeah, right. How can I motivate you to make funeral plans? Is what he just said. But I think adding that existential part. That could easily be done with this because of the fact that this is high. It's a standardized protocol that's individualized to the circumstances of the person, and so we actually didn't have anybody. We had one person who died before they started the therapy, but nobody died during the trial or during those 2 years.
And that may be,
Yeah.
that's the rates of mortality in the IC studies are like 30%.
Right,
before
right,
the trial.
right. But I think that could be done. And if somebody is truly, I mean, they can see that they are not going to recover from this, you could change that. So I think that they could be more in control and in command of those interactions they're having with others as they move toward that. That's great. I hadn't thought about that before. Thanks. Yes.
You may have said what the exclusion was, but I saw the small, number 12 that was
Uh-huh.
eligible but excluded.
Right.
What were the exclusions?
Were the exclusions? Yeah, we didn't exclude very many people.
I just wondered.
Yeah, so we excluded people who had serious psychiatric illness, other than depression. People who with yeah, and that's one of the big limitations of this is people who had aphasia sufficient that we couldn't understand them and they couldn't understand us, and that is a whole huge another group who also get depressed, and people who had sufficient drug or alcohol abuse problems that we didn't think they probably could work with us. We did not exclude people if they were homeless, so long as we could find them. And I think I can't remember how many, but we had some people who initially were homeless, and we were able to interact with them. But there were very few exclusions. Yeah, this is more like real life clinical trial than many. Other questions? I don't see anything from the folks at the remote side, and I can't see them, so I don't know if they're there. Okay, well, thank you all very much.